Quick reminder that all of the 6 webinars, recordings, and slides from across the series will be posted on our MHTTC website within a few weeks. So please do feel free to check those out. Like I was saying, we've covered the conceptual in terms of sort of philosophical foundations of this model, all the way on over to the very practical and logistical around person-centered electronic health record design. So lots of good stuff there, resources for you to check out. And then I am going to pass it off in just a minute here to our panelists for the day. And they're each going to tell you a little bit more about their background and experiences that they bring to the conversation. But I do at least want to say that each of them has a really unique but complementary lens that they're bringing to the conversation. I'm so thankful that they're here with us today because I think those are going to be woven together in a really impactful event. And I would just say from a very personal perspective myself that I have had the pleasure to collaborate and be colleagues with Bevan and Amanda and Dan for many years, in some cases, even decades. And I will tell you that in all my travels around the country, these 3 are among really the most sort of thoughtful and committed PCP champions I have ever met. So you're really in for a treat. This is going to be a great way to end our series. And now I'm going to pass it on over to Bevan.
Great. Thank you, Janice. And it's great to be here and to have a chance to chat with you all a bit about some of the work that that we do as it relates to person-centered practices. My name is Bevan Croft. I use she, her pronouns, and I direct the behavioral health team at the Human Services Research Institute. We're a nonprofit that does research and technical assistance work across mental health and substance use systems, bringing a social justice lens to the work that we do. One of my favorite roles at HSRI is to co-direct the National Center on Advancing Person-Centered Practices and Systems, which I'll tell you more about in a moment. So let's see, there we go. So I think what I'll do in this sort of trio of presentations is do like a quick overview of person-centered thinking, planning, and practice, just to make sure we're kind of comfortable with some terms, and then zoom in on the person-centered practices area in particular, and share with you ways of thinking about person-centered systems, and an example of one state that has engaged in some, I think, pretty remarkable system level transformation work in the spirit of person-centered thinking, planning, and practice. So just a bit about terms. And again, I think these are probably concepts that many of you are familiar with and even expert in. But when we think about person-centered, you can kind of think about it at 3 different levels. The first and most foundational is person-centered thinking. So in order to do person-centered planning and to have a person-centered practice, we need to be consistent in the ways that we speak and act and think, and sort of at a foundational level, see people as experts in their own lives and believe in sort of a fundamental right to self-determination, choice, control, you know, as a basic human right. And so that's regardless of diagnosis or disability. And when we apply person-centered thinking, we take the person's view, that sort of necessarily requires us to balance things like health and safety, which we're often hyper-focused on in health systems, with quality of life, well-being, and the importance of making your own choices, even if those choices are not choices that others would make. So that's person-centered thinking. It's kind of an internal concept. Person-centered planning, which I know has been a major focus of the MHTTC and is incredibly important, is one methodology that is often a kind of a cornerstone of person-centered practice, and it's really a way of organizing services and supports, paid and unpaid, around a person based on what their idea of a good life is, in ways that are directed by the person. So, it's different than traditional clinical service planning in some key fundamental ways that I think have already been covered in this series. And then person-centered practices, what I would like to submit is this is a system level concept. This is how are we aligning all of our programming, our services, so that everybody within that system is all moving in the direction of supporting person-centered plan, what's in the person-centered plan, in a person-centered way. And so we'll get into that more in the next couple of slides. So the way that in our work at the Human Services Research Institute and at NCAPS, National Center on Advancing Person-Centered Practices and Systems, the way we think about person-centered practices is moving away from like the opposite of system-centered practices. So when we have a system-centered system, we are focused on, and this is sort of the legacy system that all of us are operating within, publicly funded health and social service systems in the United States are system-centered, not person-centered. Typically, we're focused on a person's limitations and deficits. We have an eligibility focus. So based on, your level of impairment, that's what you get a certain type of services that you're eligible for that necessarily orients everything that we do toward a person's problems, towards what's wrong with a person. The system and the system's structures, forms, professional rules and boundaries, those are the parameters that we're operating within. So the supports that we're able to provide are always within the limits of, the system. So I think what I just described, that's certainly the system that I got my start working in when I was doing direct care. And it's, probably still the status quo. The aspiration or the idea that we're putting forward is to move toward a person-centered system. And so that's a system that is oriented toward building capacity and working off of strengths. So the focus, rather than on deficits, is on what are people's, what are the ways that we can, that people can fulfill their potential as members of society. Rights become really, really important. Choice becomes really important. Being able to incorporate what a person wants and needs relative to their own culture, their cultural values, what is important to them, becomes really important. And so what does this look like in sort of practice? We are doing things within the system that make it really clear that people know what to expect. So we're creating good materials and finding good ways to communicate in accessible ways about what the planning process is like, what your services are like, what the supports are like, what they can and can't do. The people who facilitate person-centered planning are very well qualified and well supported because we value their role as like central to a person-centered system. Supports are delivered in ways that are consistent with the values that I talked about. So emphasis on rights, emphasis on choice, emphasis on strengths. People with lived experience as users of the system are driving change at all levels. So they are employed by the system, they're advisors of the system. The feedback and data on experience of people who use the system are being used regularly to inform changes and to know whether we're doing well. There's a heavy emphasis on quality measurement, using the science of implementation, the science of outcomes measurement to drive how we think about knowing what people value and then getting them connected to that. Oops. Oh, sorry. I just went forward a little too much. And then finally, There we go. We're using continuous learning principles. And so I think that's going to be a big focus of the whole hour today. All right. We have a number of resources to share with you throughout this presentation. Hopefully folks will come away with a whole set of resources. And so our first one is coming up here as soon as I could figure out how to get to the next screen. There it goes. Janice and I were lucky to co-author an issue brief that SAMHSA published earlier this year that really contains a lot of the sort of fundamental information that we'll be presenting today. That is available to you, and we hope that you use it. It's a, I don't know how, 10-page brief or something like that. It could have been 80 pages if we were to fill out the detail, but that's okay. It's a start. So please take advantage of that. And another resource that I'd like to spend a little time on together is a resource that we created through the National Center on Advancing Person-Centered Practices and Systems called the Person-Centered Practices Self-Assessment. This emerged out of technical assistance that we have been doing with state agencies for, we'll be in our 7th year this fall. And the work that NCAPS is sort of unique in that it's a sort of a cross sector technical assistance center. So we work with mental health systems, behavioral health systems, as well as systems that serve people with intellectual and developmental disabilities, older adults with long-term service and support needs, brain injury programs, a number of different services. So we're sort of cross-population, cross-age, and these concepts apply and have been applied across systems, including behavioral health systems. So we created a self-assessment. It's 28 questions on like a 5-point scale. It's designed as a quality improvement tool for leadership at agencies that oversee services to reflect on how person-centered their system is. You're welcome to download the assessment, the self-assessment. We've worked with states that have just simply taken it and used it, printed it out and used it on their own. We've worked with states in more intensive sort of guided, facilitated ways, which I'll describe in a moment. But the general idea is that it's a way to really drill down and move from person-centered practices as like a fluffy, aspirational concept to something that's very concrete and that really spells out what best practice is across 8 domains of 8 ways of thinking about systems. So we have questions that ask about leadership. How well are the people in charge really aware of and embracing and promoting person-centered practice? Is there a culture of person-centered practice in the agency? And how does that show up? Are person-centered principles applied to the ways that services to the sort of entry point into the system and the way that eligibility is determined and the services are accessed? There are ways to, lots of ways, and Dan's going to be talking about this much more later, to monitor and understand whether person-centered plans are of good quality. The way that we finance services, what's in the contracts, the expectations that are placed on contracted providers can be structured in ways that promote person-centered practice. Of course, we want to think about workforce competency and case capability and making sure that the people who can engage in person-centered work are in the workforce. A 7th domain is focused on how the agency collaborates and partners with advocacy communities, with lived experience communities, with self-advocates, people with lived experience, their families and loved ones, and how that collaboration is really used in meaningful, tangible ways. And finally, the final domain is around an agency's mission and standards and whether we're applying principles of quality improvement and staying innovative to shift systems. So those are the areas covered in the self-assessment. And again, those are big domains, but they get pretty granular in the self-assessment itself.
And Bevan, if you move on, just a quick note to the audience, I am dropping live links into the chat with all these resources. So if you haven't checked that out, please do, because you can download them right in real time.
Awesome. And I forgot to mention, there's also a plain language version of the self-assessment that I find pretty useful, just to sort of, that breaks down some of the concepts into simpler language, and it can be used, or has been used, to share out with communities, just to let them know that this is what the system cares about, or this is what the system leadership are doing. So the purpose of this tool is to, or can be used to set a sort of a baseline understanding of where, where the system is at across different domains. I think it's particularly useful in sort of prioritizing areas for change, by maybe picking an area that seems to be behind other areas, or it's just sort of starting a conversation about, okay, we're moving from this legacy system that has all of these problems, that works against being person-centered, to something really aspirational and lofty. Like, where do we start? And the self-assessment, I think, is a very useful tool to start the conversation. It also can be used periodically to see if progress is being made. So it could be done every year. And so you've got a baseline or a benchmark. You've got a kind of a baseline measure of the tool, and then if you do it a year later, you can see sort of where you've grown, and where you still have room to grow. So I'll bring it into focus for you all with an example. We have been working with the state of North Dakota through NCAPS since we opened as a center 6 years ago. They have some champions within their executive leadership at the state, led by the director of the Behavioral Health Division, who really have recognized that this is an area that they want to embrace and grow and put time and energy into. And so with technical assistance support from NCAPS, and we've done some additional engagements with them through HSRI, they have created a whole person-centered practices initiative. There's a website for the initiative. It includes a number of different activities, pretty community engaged, to kind of create a community definition of person-centered practices, to identify shared principles with that definition. They engaged in an asset mapping process where they really did this intentional map of all of the different advocacy communities, groups, committees, councils that are all, sort of sharing the values of person-centered practice and interested in person-centered systems. They've had summits that are open to the community, that teach and share about person-centered practice, all of which have showcased and featured people with lived experience, sort of highlighting how and why they're important and what the system is experienced like from the end user perspective. They've done a good amount of work around community engagement and how to do community engagement. There have been a couple of different training initiatives. They've very intentionally forged partnerships with their protection and advocacy group in the state. As part of the self-assessment, have identified that they want to particularly work on supporting dignity of risk and doing education on dignity of risk. So they've developed guidance on that. So they've really accomplished a lot in the past few years, and I'm really happy to kind of be highlighting them today. But the piece of the initiative that I wanted to share most, before we do that, here's a word cloud that was done at the first summit of people sort of generating a definition of what person-centered meant to them. And this was then used to craft a definition that's on the website. But you can see individualized is the most common and prioritized word when we're thinking about person-centered for the folks in North Dakota. So for that state, for the people up in North Dakota, along with empowering, respectful, meaningful, collaborative, compassionate, lots of great words. And the initiative, this is a bit repetitive from what I've said, but the spirit of the initiative, which they've used in the messaging, is undergirded by these ideas. They want to have diverse voices at the table. They want to support people with lived experience to participate. They want to transform policies, and they want to do it in a way that focuses on good, accessible, relatable communication. Okay, so so the assessment process that they're doing now, the goal is to go through the in the state of North Dakota, they have a sort of single umbrella Health and Human Services agency that includes public health, behavioral health, intellectual development disability, aging, physical disability. Everything is all under one single agency. And they're working their way through every division within the agency, including, interestingly, I think, their communications division, their human resources department, their legal department. Medicaid is within the agency as well. And each one is engaging in the self-assessment process. The way that they're doing it is the assessment has been put online. Everyone within that agency, there's a lead designated. Everyone within that agency takes the self-assessment online, which generates a report that includes median scores, histograms of each item. So whether they rated each question or each practice on a scale of 1 to 5, with 1 being least person-centered, 5 being the most person-centered. They can actually see how every employee within that division rated themselves. We facilitate like a focus group of change makers within the division who look at the scores together and sort of interpret them and land on where they think they truly are. And then they have that baseline measurement, create an action plan. So identify specific areas. So the example of dignity of risk. So there's a question about how the agency supports people to take risks in their decision making rather than trying to sort of protect people all of the time. So that was an area that one of the divisions decided they wanted to support. And their action plan was then they wanted to move from not actively promoting this concept to providing education for all of the staff and guidance on how, within the context of this agency, they can support dignity of risk. So they communicated that to the public. Say this is an area, we went through this intentional process. This is an area we're working on, and every 9 to 12 months, they retake the self-assessment and see, are there new areas we want to work on? Did we achieve what we wanted? And they update the goals accordingly. So that's their process. And if this kind of thing is interesting to you, we have in our 6 years as a center really developed a number of different tools like this, pieces of guidance, most of which come out of technical assistance working directly with states. So these resources are all available to you if you would like to check them out. I think that's all I have. I'll pass things to Amanda.
Excellent. Thank you, Bevan. The NCAPS website is a treasure trove of resources and tools. So if you all are looking for more, that slide or just checking out their website is huge. Thank you. That's great. So this is me, Amanda Bowman. I use she, her pronouns. I identify as a clinical social worker using my lived experience with mental health challenges in my work. I got involved with the implementation of person-centered planning when I was serving as the director of social work at an inpatient psychiatric hospital here in Austin, Texas. And it really got me back in touch with why I had chosen the profession initially. It also unearthed all sorts of needs for change across the hospital, within our department, and myself, to be quite honest. So I've had the opportunity to do consulting and training with organizations for over a decade since then. And I'm excited to be able to talk with you a little bit today about some of the things that I've learned along the way that let's see, are specific to training, supervision, and what we're calling coaching. So I'm going to see if I can get, there we go. Give me just a minute here. There we go. Zoom wanted to take over my screen for a minute. So oftentimes we tend to think about training as the main mechanism for change to happen at agencies and organizations and programs. And so I'm really glad that Bevan shared a lot of examples that really go beyond just training. And Dan is going to share some examples of measurement and tools after this as well. That'll be really great to take a look at. So I want to talk with you today about some common barriers when organizations are really trying to implement meaningful change in a sustainable way across an entire agency or across a program, and some of the strategies that we have found useful in overcoming some of those barriers. But before we get started, I want to take a minute and talk about this word coaching. I feel like it's not something I hear a lot, and I want to make it clear what I mean when I say coaching. So when we hosted a program with multiple organizations. It was for what, Janice, 3.5 years. We extended the program, I think. And so we really had a lot of time to partner with organizational leaders and develop a lot of site-based capacity for not just training and supervision and leadership, but also this role that we called coaching. And so what we did was we sort of fostered some very specific subject matter expertise among a small group of leaders at the organization. They weren't necessarily all supervisors, and did coaching sessions. And those coaching sessions lasted for about an hour and were either with a single provider or maybe a multidisciplinary team. Sometimes other staff would sit in on those coaching sessions in order to learn and observe some of the feedback that was given, if that felt comfortable to people. Oftentimes, the coaching sessions felt a lot like case consultation or clinical supervision, but it really was something different because it was specifically focused on person-centered recovery principles and planning. And if you've been to any of our other webinars, you've heard Janice or I or somebody talk about the 4 Ps of person-centered recovery planning. And so I just want to bring that up again. It's really easy for staff and trainers and supervisors and leaders and quality management folks to get overly focused on documentation when really we want to focus on, you know, the process of planning and the relationships that we have with people. Another P is the product or the outcomes that we really want to see. So people, you know, and Bevan mentioned this. So, you know, quality of life improvements, those types of outcomes, rather than just looking at recidivism, right, would be a great example of that. And then also really looking at philosophy. And Bevan talked about this when she touched on culture and changing the way that people think, right? So we often kind of skip over that part of it. One of the biggest lessons learned throughout this implementation of coaching that we did is we would start by reviewing the documentation before the coaching session, but we wouldn't mention as coaches anything about documentation as we got started in the coaching session. Even though those people being coached would have their plans in front of them, they knew which person, you know, was going to be the focus of the coaching session, and they were ready to get feedback on their documents, their planning documents. And we would say, put those things aside. Let's talk about your experience in supporting this person. And once we really got people talking about the relational work that they were doing, that really helped us keep a more balanced focus on what we mean by a person-centered approach to planning. The other thing that we found when we focused on coaching, because coaches were sometimes direct supervisors, but not always, we'd have this small group of coaches that were going around one organization, maybe visiting different clinics if it was a community-based agency. And it created a lot of opportunity to feed back information to the implementation team or committee, the people that were really guiding the overall plan to make changes at the agency. So that was those feedback loops and the consistency of the messaging was really important. So that's just a little bit about what I mean when I say coaching. So here's a quick note. When we think about who influences implementation, so when we're thinking about all the changes that need to be made within a program or at an agency, you know, I was invited to talk about training, supervision, and coaching, but we know quality management staff have a huge role to play. Executive leadership has a big role to play. Sometimes people have clinical supervisors who are different than their immediate, direct report supervisors. But then you have all these informal leaders. I remember at the hospital, with the direction of Dr. Tandora and some other folks, when we first started implementing this, we were even talking about who are some staff that we can really get involved, who are champions of this work, who will have kind of this informal influence over the process. So, everybody has a role to play, both in setting up your implementation plans, but also as you're moving through and figuring out how things are going. So let's think a little bit more about the structure and support needed to have really strong quality training, supervision, and coaching and those sorts of things. These skills are not easy. So really setting aside time and opportunity for people who are leading the efforts at the organization to compare and contrast what they're seeing, what they're running into. Nuanced messaging, I found, can make a really big difference in making sure that the staff and the people being supported to make the changes are really clear on the expectations. So one resource that we want to provide to you is a handout on coaching competencies. And that can also be extremely useful to people who are in supervisor positions as well. Okay, so we've outlined the complexity, I feel like. We've started to talk about all the things that need to happen in order for, sustainable change to occur across a program or an agency. I don't know if any of you all have run into this, probably so. Oftentimes staff can get really frustrated when they're not hearing the same messages, right? There's a lot going on. Another thing that happens is some staff might be left out of an effort when they really have a huge opportunity to further the implementation project and really reinforce some of those cultural changes that we're talking about. For example, front desk staff, right? Reinforcing some of the philosophical and the principles of person-centered planning. We've also found that having one person responsible for coordinating the effort and really, making sure that trainers, coaches, and supervisors really have what they need to be communicating with each other and sending the consistent messaging to staff. Having one person responsible for that coordination is really a best practice. Okay, so is anybody feeling a little bit overwhelmed? We're talking about all the things that need to change and that you need to keep your eye on. But don't worry, there are some easy ways to manage the overwhelm of all these things that need to happen. And Dana's going to help me out with this here in just a second as well. Making the changes that you want to see happen really concrete. Devin mentioned this. When you're starting to map out your implementation plans at your program or your agency, really making sure that you have a strong sense of where you're starting from. So taking time to assess, looking, at your training materials, your supervisor skills and competencies, making sure that everybody is ready before you begin to change and implement the person-centered approach. So I guess kind of a big takeaway is don't rush through things, set priorities, and make sure that you have a phased approach. So one of the things that we mean by that is thinking about what are the outcomes that you want to see first, and picking some things that you can focus on as supervisors, as trainers, that are really simple to understand, that are maybe even easy to measure as you go along, but that also impact the culture and the thinking again. And I want to give an example of this. At the hospital, we decided that one of the first big changes that we were going to make in our policy, we were going to ask all staff in their documentation to refer to the person being supported by their name. Everybody was referring to people in the third person, patient this, patient that, client this, client that. We said, you know what, this is so easy to understand. It's easy to measure because we can look at notes. Start referring to people by their name. And that really, I think, sent the message to everybody that worked at the agency that we were really serious about making some changes in how we approach our work rather than just, kind of the window dressing approach. Another common barrier, of course, is that we're already asking a lot of people working in the system, of employees, right? There is burnout, there is change fatigue. When I work with organizations, we hear, oh my gosh, what's being changed this week, right? Every week there's updates to our forms, there's updates to the electronic health record, there's new policies and procedures that I have to follow. So it's really important that we emphasize that we are taking a phased approach. We can say, maybe next year we're going to focus on this. This is coming up. But right now, we really want you to focus on these 1 or 2 changes. So having supervisors and trainers really pick a handful of things and be really consistent and focused on those things, I think will yield great results. Also being curious when you do meet resistance from people working at the agency, people that you're asking to change the way they're doing business. Sometimes they have really good things to point out, right? Real barriers that they're running into. So I think it's really easy when we're coming up with a new training program or we're implementing a new set of standards to think that information is one directional, right? We're the experts and we're letting everybody at the agency know what we expect of them now. We really want to make sure that there's 2-directional learning going on among staff and trainers and supervisors and leaders. The resource that I keep going back to, even though, yes, Janice, it's very old, but we all still value it very much. Janice co-wrote an article on the top 10 concerns that staff have about person-centered planning. And it offers some really, really great ideas for how to address some of those concerns. So that's a resource you might want to check out. Another great note, and I think this is something we all know when we hear it, but it's really easy to forget. It was for me when I was in a supervisor position at the hospital, is really acknowledging where you're starting from with your strengths as well. So when you start to meet with supervisees or with employees as a trainer at the agency, really giving people credit for what they're already doing well, and really making time and space to celebrate those wins and those strengths as an agency. So maybe it's a standing agenda item at department meetings. Maybe there is a newsletter that goes out, sharing stories of people being person-centered, but really making space, not just for the critical feedback, but for the strengths-based approach as well. And very similar to that, there are a lot of benefits to the person-centered approach to staff. Most people that are choosing to do this work are doing it because they're passionate about it, right? And so I think being able to focus as a trainer, coach, teacher, leader at your organization on the aspects of person-centered recovery planning that really do enrich the work and benefit employees is also an excellent approach. And it helps to minimize power struggles that you might otherwise be encountering when you're asking employees to change the way they're working. Another thing is to be concrete and help people that are doing the direct work really understand what's being asked of them through examples, stories, and we're gonna give you access to a few resources here that assist with that. So there's a tip sheet on developing a strong objective, which is also kind of like a short-term measurable goal. We've got a little vignette activity that's in a PowerPoint that you're welcome to check out. And also a basic framework for person-centered recovery planning that includes some sample questions that providers can ask to get at that information.
And Amanda, just again, a reminder to the audience that I'm dropping all of these into the chat as you refer to them. So please check.
Perfect. And they are also linked in the slides themselves. So if you get a copy of our slides, you'll have all the links to the resources as well. And then kind of last on my list is to really think about not just communicating new expectations to staff and measuring whether or not they're doing it, but really thinking about action steps that can produce change, and encouraging people that are under your supervision or getting training or on your team to help identify what some of those action steps may be. Maybe they want to start a consultation group where they're talking about, being person-centered. So, coming up with those different ideas. So just want to review the takeaways that I've gone over with you. And if you haven't picked up on this, there's a parallel here. All of my recommendations to you for supervisors, trainers, people who are teaching person-centered recovery planning at their agency, there's a parallel with person-centered recovery planning itself. You haven't picked up on that, right? So taking time to assess where you're starting from, right? That's a key element of PCRP itself. Coordination among all the people that are involved. Taking a phased approach, right? Building on that incremental success. Setting priorities. We always say on person-centered recovery plans, don't try to bite off too much change at one time. Same goes for agencies and leaders. Strengths-based approach. Emphasizing the benefits to the people doing the work, which I see is very parallel to a meaningful goal or the why. Why are we doing this? How does it connect to the mission of the work or the mission of our program? Making time to measure outcomes in your implementation process, which is what Dan is going to take over and talk a little bit more about as well. And then last, being really creative and being action oriented for how you're going to spark change throughout the program or the agency with creative action, and asking staff and employees to take action that's maybe new and different and report back how it goes. So thank you for the work that you do. Wish I had more time. Dan, I'm handing it over to you.
Thank you, Amanda and Bevan. Let me see if I can seize control of the screen. Okay. So hi, everybody. Good afternoon. I'm Dan Wartenberg. I've been doing this work for some time, and particularly doing the person-centered work. Actually, I've been working with Janice for more than 20 years now. Not to ouch you on any age thing or anything, but I've had a number of roles. So I first encountered Janice when I was working in the state-operated mental health system in Connecticut, working in a large local mental health authority. Had a number of roles there, including running an inpatient unit, an outpatient unit. Was the quality director for several years, and eventually became the clinical director and the CEO. I've also worked in a not-profit community mental health center in Rhode Island, and have been a practicing psychologist all along the way. So today I want to talk to you largely from the perspective of quality director, or having a quality program, but also all those other hats come into play. So when you're creating a quality program, as a leader, there are a lot of decisions to be made about what you look at, when you look at it, how much do you bite off, what do you emphasize, do you devote your resources to actually following the whole quality process through. And then as a provider, how does that impact me, as the person on the ground that is trying to do my best to work up all these confusing new principles that I kind of understand, but are really complex and I'm trying to grasp. Okay, so I'd like to give you just some general thoughts on approaching the work, and then do a little bit of a more detailed dive on, some of the areas within person-centered care that you can be assessing and doing some real great quality work on. It's pretty amazing how the technology has evolved in 20 years. When we first started doing this work, there was a lot of sort of the seat of your pants. How do we know what's going on here? And I think through a lot of work through Janice and people like Bevan and Amanda, we've really developed a technology over the years where you can get a better sense of how you're doing, and get much more focused on how to dig in and improve. All right, let me see if my screen control works. Okay. Let's try that again. Yes, okay. So again, I'm going to focus a bit on the quality piece. As Bevan mentioned, this is a large and complex concept with all different facets to it. And part of what you have to do as a leader and then translate into quality is make the choices about when and where to focus on different things. So today I'm gonna talk more about the sort of the quality and innovation piece. Okay. Okay, and again, same idea. even within person-centered planning, there are multiple sort of concepts or idea. Okay, there's the documentation. There is the process. There is the relationship. Are collaborations happening? Okay, are we respecting rights, choice, and control? Okay, so they're all different aspects, and we really have developed some pretty good tools at looking at them. Okay. So just a few sort of general thoughts here. So as both Bevan and Amanda had mentioned, your quality implementation is not taking place in a vacuum, right? If it was the only thing that people were doing, this would be easy, but it's not. There are multiple priorities within quality PCC implementation, and multiple competing priorities. People are funded by grants that all have their requirements, that you have to carve it out. Okay, so you have to carve out the time and the space, both to do the implementation and for the what I'm going to call the parallel process of the quality assessment that goes with it. Because for every step of the way, okay, you want to sort of have some way to know how you're doing. Okay, and that's where you sort of build your quality. Your quality improvement activity should mirror your implementation, and where you are in the implementation and the priority decisions you've made in your implementation, both in terms of what information you collect and then how you respond to the data. Okay, so for example, if you're just introducing the concept and you're looking at the documentation, everybody's struggling with it in the beginning, the feedback might be different, and the expectations are going to be different than for somebody who's been trying to do this for 2 years. Okay, so just knowing where you are as an agency and knowing where the different people that you're working with are sort of in that continuum are really important. Okay, both the documentation and the sort of the process. So again, both Bevan and Amanda talked about it's just not the plan. So when we talk about person-centered planning, we tend to think of the plan. There is a lot more to it. It's how people think, it's how they interact, and the relationships they form. Okay, so there's a tendency to measure that which is most easily measurable. Okay, and that tends to be the documentation, right? It's right there. You do a chart. We all know how to do a chart audit. Once you have the tool, we can do our chart audit. We can compile our results. We know what to do. That's really important, but it's not the only thing. Okay, so I just really want to make that point really strongly. Okay, information can come from different places. So one, I just mentioned the audit. Again, you have the medical record, especially with electronic health records. Sometimes you can just pull stuff right out. Observation, we talked about, Amanda was talking about how the coaches, if you're going to coach somebody, you have to know how they're doing. And to know how they're doing, you need more than just what they've written. You have to see how they talk to somebody. You have to see how they respond to the nuances of the interactions. And to do that, you have to observe. And you need somebody, the person doing the observing needs to know enough to be able to respond appropriately and understand what they're seeing. And then the last piece, which probably is the most neglected, is get some direct feedback from the person that who are receiving the services. I think you will consistently find differences between the staff's perception of what is transpiring and the perceptions of the people who are actually the recipients of service. Okay, so no matter where you are in your implementation, kind of keep in mind it's important to mix up and diversify your sources of information so you're getting the different viewpoints. Okay. All right, come on. I'm trying. I'm having a little, there we go. Okay, so I want to start with this whole idea of process and looking at the process of person-centered care. I'm going to tell you a quick story that just sort of illustrates this. One of my positions early on was the unit chief of an inpatient unit on a sort of a longer term unit within the state system. Okay. And we were required to do, we called it treatment planning at the time, every week. And not only that, but coordinate it with the outpatient providers. So there were 20 people in the unit, and it became quite the logistical challenge to get all this done, getting all the input from the outpatient providers and organizing this work. Okay. And I was really pleased with myself. We had developed a really efficient system. And there was one guy on the unit, actually, Janice knows him, he went on to become quite an advocate in the person-centered world. I'm going to call him John, but every time we'd have a session, he'd come and he'd go do this. I don't know if you can see, he'd wave his hands back and forth, back and forth. And I said, you know, I have to ask you, John, what the heck are you talking about here? And he said, Dr. Dan, that's what he called me, move them in, move them out, move them in, move them out. And it still sticks with me all these years later that here we had, when Bevan was talking about system-focused systems, we had created this highly efficient system to sort of move all the people through, but his experience was one of sort of being on a conveyor belt, you know? And it took, you know, asking him about that to really understand what that is. So my point here is that process is really important. If you ask people what they remember about their care, it's not, I had this fantastic plan, you know, it's the interactions they've had with somebody or the relations they form. Okay, so what do you look for when you're looking at the process? I think there's some key elements. Number one, are people covering the things that should be in a person-centered plan? So you can look at your documentation for that, but you also want to see if they're actually being talked about. And in the discussion, are both sides being weighed equally, or is a staff person kind of dictating to the person what should be in there? Okay, so for example, is there a robust discussion of goals and having a meaningful life, which is really the heart of a person-centered plan, and the whole identification of strengths and talents, and not only identifying them, but how do you sort of bring that into the plan? Is the process respectful and empowering? Okay. What's the tone look like? What's a person's affect as the interactions taking place? Are they actively engaged? Do you see people sort of shrinking back? During the meeting, do providers regularly invite the person's input and check for understanding of questions? Is it a true dialogue? Okay. The tools and processes that foster self-efficacy and recovery are built into the process. Okay, so things like having a peer specialist involved, are people being asked if they have a RAP, or is RAP being involved into the process? Again, they're all sort of keys that there's a true, robust, person-centered process taking place. So those items I actually pulled out of this tool. Okay, so this is one of the tip sheets from the recovery roadmap, which is a really good tool for sort of what are the things I want to look for in the process. And this tool is sort of readily turned into a rating scale. Okay, so a couple things on this. One, you want to probably have a version that is both observational and a version that is a self-report. And those versions both exist. Okay, so again, that point about asking the person who's receiving the services what their experience is, it not only gathers your information, but it conveys your respect to them about the importance of their opinion. Okay, so again, I talked about some of the items. Here's a few more here. The individual's talents, capabilities, and strengths are discussed in the meetings. You're showing awareness and sensitivity to cultural background, and that's built into the planning. And the person's offered education about strengths, wellness tools, advanced directives. Again, there are several items on here. I highly recommend you take a look at it. It just helps focus your thinking. And remember, when you're doing your assessment, you may not be doing all these things at the same time. You may want to do a sort of baseline to kind of see where your staff is. And based on that, or based on what you're training, hone in on a couple individuals. Again, these are complex skills you're asking people to develop, and you want to give them time to do it and allow some mastery. Okay. Oop, I think I went too far. Nope. Ah. Stop it. All right. Well, for some reason, I can't kind of get it. Okay, good.
Slide control is not all it's cracked up to be, Dan.
I was going to say
temperamental.
the old guy trying to deal with technology, but hey.
The
All right.
roadmap tips are in the chat for folks if they want to download them.
Okay, so I do want to take a minute just to talk about the sort of the documentation review and the audit. Again, not just it's critical, it's a great way to teach. It can be used both on an individual level for supervisory or a coaching tool, and on a systems level to kind of see, you know, where you might want to hone in on some of your training and your intervention. So I think Janice can tell you that there are certain predictable things that people struggle with more when implementing writing person-centered plans. Okay, writing measurable objectives is one of them. Okay, right? You know, but you should get your data to sort of indicate that, and it shows you where your kind of system level interventions are meeting. And by intervention, I mean training or coaching or supervision to help to sort of bolster those areas. You know, and again, this is just a sampling of some of the items, but it basically takes the components of a person-centered plan and turns them into sort of rateable items. I got it. Okay, one more try. So this is just a sample. This the agency I work with, shout out to Newport Mental Health. We actually did this in conjunction with the implementation of a whole new electronic health record that were kind of built on these principles. But what we do is we took these ideas and we basically turned them into a rating scale. We found it useful to be very detailed in our elaborations so people knew what we were talking about, but took the elements that were showing up in the tips sheet and basically turned them into a rating scale. And Janice is dropping that one in now. It worked really well. And again, just to go back to what Amanda said, how and when you use it is really critical, because there is a learning curve on this. Okay, and again, with any quality activity, all right. I got it. And one more try. Okay, I'm trying. There we go. Sorry, folks. All right. So just a few last thoughts. This is general to all quality implementation. The best way to turn off your staff is not to use the information that you collect. Okay, so be thoughtful about making use and making very obvious and public use of the information you're collecting. If you're going to ask people to record data or complete surveys or do this, make sure you use it. Okay, and I know that would be great data. Let's do that. Let's get some of that, and then I have too many things, so we don't get to it. Again, some way you need to communicate that person-centered care and person-centered planning are a priority. You got to carve it out. It's the only way to do it. The reality of the agencies we all work in, they are competing priorities. Okay. Make sure you devote sufficient resources to your QI processes to see the process through. Okay. You both have to, again, making the choices about what to measure, reliably collecting information, turning the findings into something understandable that people can use, and then actually taking actionable steps based on your data. Okay. And just, again, you need the expertise, and think about, again, in the timing of your QI activities. You need people in-house or through consultation that have the expertise to know what to make of the data that you get. Okay. Okay. Let's. And then again, this is just an example of how to play that through. So I'm actually gonna bypass this one because we're running a little late here. But thank you all, and I wish you all well with your implementations.
Thank you so much, Dan, and thanks everyone for your patience with our slide control. I'm actually going to have Christine take it back from us because it's finicky when you're trying to make your remarks in advance at the same time. So let me just jump back in with a couple of concluding comments, and please do. Lots of resources, links to everything dropped into the chat. And please do put any questions. I've been scrolling through, and other folks have as well. I'm not seeing any, but feel free to drop them in. And Christine, if you can go to the next slide for us. Is our best laid plan not working? What we have, we may have lost Christine off of the platform. I'm not seeing Christine.
Oh, she's back. Here she is.
Oh, okay.
Sorry, my Zoom just disconnected. I'm sorry.
That's all right. I just thought for a minute. Okay, so Christine is going to control the slides. And Christine, if you can go to the slide at the end, the master slide of the resources and tools, that's where we want to be. So throughout the presentation, we have dropped all of these links into the chat. If you did not have an opportunity to grab them, they're all hyperlinked in the slides, which will be available with the along with the recording, usually within about a week or so on our website. And just, I want to say just a huge thank you again to our presenters for the remarks and the resources that they offered today. I mean, as I anticipated, it was really just a wonderful way for us to end this Consultation Corner series. So we're going to move it on over here. Let me say one more thing before we invite a couple of last minute questions or comments. I just want to point out to folks, if you're not already aware, the work of the MHTTC and the 10 regional centers is actually going to be coming to a close in a little over a month on September 29th, after 6 really incredible and productive years. And across those years, we have produced collectively such a rich repository of products and tools and resources and archived webinars. And I just want to make sure that people know where to find us after September 29th. So we are in the process of migrating over the large majority of the various MHTTC resources, including all of these person-centered recovery planning resources, to the website of the Yale Program for Recovery and Community Health, which you see the link up here on the screen to, which will be live when you get the slides. If you have PCRP specific inquiries, feel free to reach out to me directly. My email address is in the slides here. And again, you'll have access to all of this when that email gets set out. And if we can just go for a back up one slide before I open it for any kind of questions or comments from co-presenters or the audience. As I was listening to Bevan and Amanda and Dan really talk, I was trying to just really think about, and then was really impressed by kind of an interwoven theme across all of their remarks. And if it wasn't apparent to you, what I would say, and this is a really, I think, a wonderful sort of remark to share in our last concluding webinar, but if you get one thing right in your person-centered recovery planning implementation efforts, it's always to go back to the guiding post that everything you do has to actively engage and be informed by people with lived experience, right? So we talk about that a lot of times at the micro level and the planning process itself. But as our 3 presenters were talking about today, I love how Amanda referenced the parallel process, right? Because it's about engaging people with lived experience as trainers and co-facilitators, making sure that they're involved in quality improvement teams. I mean, I think I thought the most fascinating quality improvement team was a combination of a state hospital psychiatrist and the leader of the peer support program. Together, we're doing observational audits of PCP meetings in the hospital, right? So involving folks directly in quality management. Bevan talked about the critical nature of policies and procedures. And then even in training and workforce development, as Amanda's talking about, we can't just build capacity in this partnership equation on only this side of staff. We have to build capacity and confidence among people in recovery. So if you get one thing right, go back to that as your guidepost to always go back to engaging and being informed by lived experience. And I just wanted to thank all 3 of the folks today for really highlighting that. And with that, we do have a couple of minutes here. We're pretty good with our time management. I'm wondering if folks want to put anything in the chat, or we are actually turned out to be a small enough group today that if you wanted to unmute, certainly feel free to do that. Or Amanda, Dan, Bevan, if there's anything that you folks would like to add here before we move on over to our evaluation link, we'll give you a minute to watch the chat. I am thinking since we lost the slides, we just lost Christine again.
No, I'm still here.
Oh, okay. That's all right. Any questions out there in the audience? We have a couple of comments in the chat box. Stephanie points out how much she really loves person-centered planning, right? It makes sense, it's the right thing to do, but how unbelievably complicated it gets when we start braiding together funding streams, intersecting with policies and procedures. And my remark to Stephanie, if you didn't see it in the chat, was that was exactly why we chose to focus this webinar, this concluding webinar, on this topic, because without transformational leadership that's honestly invested in and committed to systems alignment, it's very difficult to get traction with your implementation. Christine, can you do me a favor? Can you pull up the evaluation link just so that we have that, so that people can grab this before we go? So the link is in the chat and also on the QR code on the screen, whichever you prefer.
Janice, someone has their hand up. Jacqueline.
Sure, Jacqueline, why don't you go ahead and unmute?
Hi, I just want to say thank you. The training has been real enlightening. I've been in this field for a long time, and I've seen so many different aspects of it. I heard a lot of information, and person-centered planning is real good. I like that it's lived experience and the goals expressed that people have a meaningful life, and actually that people have a say in the meaningful life part of it, and doing RAP and being in the transformation network, a part of the system. It's really important that because peers are so valuable and big in the workforce. It's a big, big thing because I see a lot of peers doing a lot of different things that with their lived experiences, there's a lot of tragic situations, and it needs to be more monitored. I don't know. I just see a lot of stuff that this person-centered planning thing really need to be implemented more. Just not knowing where I fit in. I got a lot out of the training. Having my own person-centered plan, as well as my RAP plan, putting more into it for me to be able to utilize it with my friends is really essential. I have a lot of people that ask me a lot of questions, and I say, have your own plan. A lot of people have recovery coaches now that are, that's very, I question.
Yeah.
So I'm going to really make use of this and really spread what I learned.
Well,
So thank you very much.
we
Thank you
appreciate
very
having
much.
you. Thanks, Jacqueline. We appreciate having you as a bit of an ambassador to help kind of carry this in the field. And hopefully we've gotten into lots of tools and tips to answer those questions. One thing you mentioned, just as a reminder, Jacqueline talked about sort of the interface of peer support and person-centered planning. And that was the dedicated topic of our session 3 webinar in this series. So if folks are interested in the ways in which to integrate peer specialists in a way that is role consistent and aligned with peer ethics, right? Kind of the shoulds and the should nots. Please feel free to check out that webinar. And AJ is making a great comment in the chat that there's other tools that we can draw upon that also have person-centered planning foundations. So this is very consistent with some of the best practice wraparound that you see out in the field. So, again, there's lots of PCP models out there. Our intent has never been to endorse sort of one model or way of doing things, but just to make sure people are aware of all the tools that are out there, whether they're the wraparound model, person-centered thinking, life course, our recovery roadmap work. So thanks for reminding us, AJ, about the utility there of wraparound. All right. Going once, going twice. Well, thank you everyone for being here today with us. I was really pleased again to end the series on this particular topic. And big thanks to our presenters, and enjoy the rest of your afternoon. Thanks for being here with us today. Take care, everyone.
Bye, everyone.
Thank you.